David, and I'm delighted to be here. You guys look slightly different with your clothes on. I'm pretty sure I saw some of you at the beach yesterday, and you looked a bit different. I also need to have a bit of a disclaimer that I think you are here to find out about integration in mental health care. Well, I am a fraud. I don't know if it's the conference's first fraud for 2019, but I'm here to tell you about disintegration. So I'll go quickly through what I will talk about. I'll give a quick overview of mental health in Australia. I'll talk about the 5th mental health plan. We have 5. You can't have too many plans. We have an introduction to the ACT, which is where I'm from, and our understanding of what we mean by integration. And then I'll quickly, as a model, tell you about what we did. How did we execute our goal of integration? What did we do? What has happened subsequently? And then I want to have a discussion about what does this mean for integrated care in the ACT. And there will be begging at the end, where I plead for some assistance, and I'm hoping you can help me. I won't spend very long on this because it's just important to locate things about mental health in Australia. So we know that we have lifted the rate of access to care, which is great. We know that it's about 12% of the burden of disease, but it only gets about 7% of the total health budget. And I think it's fair to say that the overwhelming focus is on hospital-based care still, either as an inpatient or an outpatient over community-based care. Things do vary a little across our jurisdictions, but that's fair enough. And in terms of the budget, it was about 7.4% 10 years ago, and it's about 7.4% now, so nothing's really changed. I think a lot of people in Australia think that things have changed, but I don't think the evidence is strong to support that. And we know that 1 in 5 adults per year will have a mental health problem, and we also know that it's a young person's problem. And I think this is really critical, and you think that 75% of all mental illness manifests before the age of 25, that of treatment rates for young men, aged 16 to 24, who suggested they had a mental illness last year that needed assistance, only 13% of them got any care. So there are big gaps in the way we provide things, and our money is split between federal and state governments and others, but that gives you a quick indication. Now, I understand the Commonwealth Fund are doing a presentation later on this afternoon. If anybody wants to come and help me badger the Commonwealth Fund, then about how you compare across countries, then you're welcome to do that. I think Australia regularly is shown as having the 2nd or 3rd best health system in the world, and that's largely because they don't count mental health. Now, I did some research myself about mental health in Australia, and there are 95 countries that have a lower rate of suicide than Australia. There are 25 countries that have lower rates of homelessness. There are 19 countries that are better at finding employment, education and training than Australia, and so on. We spend there are about 7 countries that spend more than us. We have the 3rd and 4th highest rehospitalisation rates for schizophrenia and bipolar. So I think this is really important. So my contention with the Commonwealth Fund, not to be distracted from what we're doing here this morning, is that we need to be thinking about mental health if we're going to take a whole of country comparison kind of approach. Anyway, Australia has got a lot to do. I said we have 5 plans, and here they are. Well, here's the last one of them. And what it did was it sheeted home responsibility to regions to commission and deliver services. And it expected that these primary health networks, these primary health networks, would work with local health districts, local hospital districts, the state-funded tertiary care, the hospitals, and ambulatory-funded or state-funded ambulatory care will work together. And there was a concept of stepped care to counter this lack of integration. But overall, if you've got the federal government funding hospitals, and you've got the federal government funding GPs and primary care, and you've got the state system funding hospitals, who's funding the services in the middle? I won't spend long talking about this. You know more about this than I do, but obviously integrated care has a focus on prevention and primary care, and there's different types of integration, real, virtual and so on. And we thought that this set for us a very nice platform for us to work together. And there were important principles of equity and holistic care which fitted well and remain well suited to our local ACT government. So who are we? It's a very pretty place where I live. But as you can see, it's a tiny dot in a large landmass. It houses Canberra, and it has about 420,000 people. It's the second fastest growing region in Australia, 9,000 people a year, which is quite a lot from an Australian point of view. And you have to think about how many roads, how many toilets, how many schools, how many ovals, and so on. There are about 80,000 ACT residents with a mental health problem every year, and about 33 Canberrans die from suicide, and we don't spend the smallest amount of money. We're a middle-ranking spender, and we have very high rates of community follow-up. So in my mind, as a layperson, if you like, thinking about integrated care, the basis, again, the platform for us to undertake work around integrated care seemed okay. The community follow-up suggested that the link between the state-funded hospital service and the federally funded primary care service was probably not working too badly. So we have some advantages. We have a small size geography. We have relatively small demand. We have got a small workforce. Now, I put that down as an advantage, and maybe this is just being naive, but the reason I put it down as an advantage is because everybody knows each other or is married to one another. We'll come to that later. So we have a relative abundance of services as well. So that's also in our favour in comparison to some parts of Australia. There are services around. There's also been some continuity. We've had lots of changes in the way the federal government and the state government organise themselves and organise their funding. But the Primary Health Network, the PHN, and ACT Health, the local state-funded service, have been working together for some time. They know each other. We've got the lowest rate of seclusion in Australia. We have a well-educated population, and there are no rural areas. Again, in Australia, there's some massive distances, and David can talk about that in terms of access to services in rural areas. But in Canberra, we are a city-state. Disadvantages. So we do have some shortages, particularly in things like psychiatry. We've also got evidence of more corporate organisational structures managing primary care. So there used to be local, small GP businesses, if you like. Now we're finding bigger GP businesses moving in and creating large corporate businesses with perhaps less attention to your needs, your particular needs. There are lots of organisations. Our, if you like, left-of-centre government in Canberra has always funded the social sector, and so there are lots of organisations that are operating, and unfortunately that makes connections quite challenging, which is why I've talked about herding cats. It's the cats all go off in their own way. It's very difficult to make people work together in that regard. So there are lots of gaps, that means, between organisations for people to get lost in. Luis Salvador Carrillo, who's a great friend of ICIC, has developed the Integrated Mental Health Atlas and has applied it in the ACT, and has found that we lack acute and subacute residential care, we lack day care. I have to say that's a term that is hard to understand in an Australian context, but I know what he's talking about. We also have a paucity of employment-related services, and we also lack services for what is a very extensive non-English speaking community in our town. So, an integrated regional plan for the ACT. What did we do? We did the sort of things that people do. I picked up the manual and opened it up on page 1, and this is the sort of thing that you do. You form a management group and you go beyond health, because mental health is about the social determinants of health as well as it is about clinical services. It's about psychosocial, it's about quality of life and so on. And it included education and housing and the community sector, consumers and carers and others. From that group, we formed an action group, and we developed case studies of typical patient journeys, which sort of represented something like 80% of the core business of mental health in the ACT. We looked for those case studies at where there were blockages now, and we looked at possible points of novel intervention. What could we do in this journey to try and make it easier for the person and for their family? And then we exposed those journeys to broad critique, to the community, to consumers, to carers, and online. And then out of that, we developed a list of possible places to start. So I reckon that looked pretty good, pretty robust. What did we find? Well, we found that service integration was a really important theme which underpinned the places to start, because people saw there were silos. Are you funded by the state? Are you funded by the federal? Are you an NGO? Are you a government organisation? And we also found, again, not surprisingly, that what people wanted to see and could recommend was the idea about bringing funds together, co-commissioning. Shared care, more of an idea around the IT and information management type things to support shared approaches to care. A focus on the workforce, people understood that you can't do anything unless you have a supported and healthy workforce, and that's not the case in many parts of Australia, including Canberra, in relation to mental health. And people also wanted to shift away from using the hospital as the front door of care and to shift more towards prevention, early intervention in the community. So what has happened? So again, to this point, in my mind, I'm thinking I am helping manage a process that has got some integrity. I use that word carefully. So what happened in the meantime? Well, the public ACT state-funded mental health service split into policy and provider arms. Don't ask me to explain why. The federal government also said, yeah, like the idea of regional autonomy and the primary health networks, but whatever you do, it needs to look like this. So the limits about autonomy, I think, are becoming more clear, more central control. There's also a new Office for Mental Health that's been established in the ACT that had to be accommodated in its role. So I think we're starting to get to the rubber hitting the road here. Having clients in common is not necessarily enough of a reason for key players to come together. Most of their clients and most of the focus of their work are, and of course the dollars which underpin their actions, are all separate. In a big picture, if I can be very crude about this, the federal government, through primary care, if you like, pay for a response to high prevalence disorders, anxiety and depression in particular, whereas the state-funded services in hospitals would be more likely to look for and respond to people in acute need, often with low prevalence disorders, bipolar, schizophrenia and so on. So even where you're able to map a group of shared clients, they aren't all separate, it's still difficult to create space for collective action. We have a large psychosocial sector in the ACT, which is rare. These are people who are providing a whole range of what's called non-clinical support, but they do a whole range of different things to help people live well in the community, and they actually offer something akin to secondary care. But neither primary care nor tertiary care have ever really treated the psychosocial sector like a partner. And now we have a new National Disability Insurance Scheme. We're a very rich country and we're looking to invest in better care for people with disability. But the money for that has come from the psychosocial sector, which means that that sector has been greatly impacted. I guess overall, in looking at this, there wasn't really a clear final model or a destination. There wasn't any funding for change. I was interested to see here Anne Hendry's approach in Scotland, where funding for change around integration, although she was looking at older people in particular, had to be funded. Change is not free. Change costs money. So, I'm winding up. How to create shared value? It seems to me as though even though we all know each other, we can all fit in a telephone booth in Canberra. We've all been doing this for a long time. There still isn't necessarily shared value. So, for example, again, thinking about Anne Hendry in Scotland this morning and other things that you read about the value of integrated care, one of the principles, for example, that would underpin it is hospital avoidance. if at all possible, to try and treat the person before having to go to expensive and often traumatic hospital care. But hospital avoidance isn't part of our fifth plan. It's not mentioned. And then, of course, there's professional and industrial boundaries which negate integration. So there still is a lack of a willingness, if you like, for people to work together. And what matters is the silo. And here an example is that we have a small service that uses coaches or peers to provide low-intensity support based on the UK's IAPT model, and that's proven to be very successful. But there are concerns around that because they're not seen to be professional. So how do we support service integration with the funding integration necessary to support new approaches? Because palpably our funding does not support integration. And how do we establish effective outcomes reporting without perpetuating a culture of blame? And I'm just sort of finding this out as I'm talking to these. Some of the staff in our psych wards look like they have PTSD because they are used to being blamed for failure. And so how do we create the situation where we can collect and report information without encouraging this concept of blame? And if that's just a selection of some of the key jobs, I feel again as though we've been concentrating very much on the funders and on the service providers and the professionals and so on. How do we do all of that and try to keep the patient and their family at the centre? And that's really a critical matter. So I'm looking for any help or suggestions, and I apologise for my fraudulent conduct. As I say, I think that we are here and integrated care is there. It's a very long journey, and what I'm looking for in this context from you would be some help about even some small baby steps to get me started in the right direction. Thank you.